Hello, I'm Michael Pearson. This is The Human Condition. In our You Need to Know segment, we're going to talk about oral galvanism very briefly right now. Oral galvanism is electrical activities, direct current in the mouth that are not supposed to be there. This is a controversial topic in dentistry. There are dentists who vehemently believe that this is a terrible thing and no one should measure oral galvanism and it doesn't tell you anything. Well, I'm not here to measure oral galvanism for pathology. I'm here to measure oral galvanism for functional neurology, and let me explain why. Many years ago in Minneapolis, I worked in the largest holistic dental practice with a wonderful dentist named Dr. Ron King, who is no longer with us. He was a dear friend of mine, and he served on the dental board of Minnesota for years under the governor, Jesse Ventura. He was appointed, and he represented alternative medicine and dentistry on the Minnesota Dental Board. In his practice, we worked together on problems with people that had very strange pseudo-stroke-like symptoms. And what would happen with these patients is they would have episodes of transient ischemic attacks. They would have paralysis of their face that would come and go, paralysis of their arm or leg, hemiparesis, one side of their body, would come and go. They would have episodes of tic douloureux or facial pain. They would have episodes of Bell's palsy where their face would be paralyzed on one side. They would have strange tongue symptoms and intraoral symptoms in their mouth. They would have buzzing or clicking or perceptions of the soft palate in the back of their mouth, which can undergo some spasms. All kinds of very strange brainstem-based symptoms would happen to these patients. And so one of the things that Ron and I started to do was to measure oral galvanism, which is to say the dentist would place two electrodes in the mouth, touching a tooth and touching a ground like the gums, or touching under the tongue, some other electrical reference point on the mouth. And I never performed these tests, but the dentist would perform them. And they would map the mouth, and they would go from tooth one all the way through all the teeth, testing each tooth to see if there was any extra direct current coming off of a tooth, and whether it was positive or negative. Usually the gold ones were electropositive, and the amalgam ones that are 47% mercury would be electronegative. There are also stainless steel bases for porcelain veneer crowns, and the stainless steel base has a lot of nickel in it, and those were usually electronegative, as I recall. But a dentist will clarify. I'm not a dentist. So we would map these places on their mouth and find that there were certain areas that had far higher than background noise of direct current. Now, where does oral galvanism come from? Originally, it was used before X-ray was developed, late 1800s, 1885 to 95, by Röntgen. And before X-rays, one of the ways that a dentist could figure out if a person had a decayed tooth was they could put a couple of wires, a couple of electrodes across a tooth and a ground, or a reference point, and they could measure with a Wheatstone bridge, which is a galvanometer. They could measure if there was direct current going one way or the other, and there shouldn't be, because teeth are insulators. If teeth are healthy, they're insulators. They insulate against electric current because they have enamel, and so they act as a ceramic type insulator. If, however, a tooth has decay and it's become soft and it's got a dental caries in it, some kind of a infection and cavity, then that soft spot will conduct electricity, and it will conduct direct current, and it will be a way of detecting tooth decay. Now, you'd have to have a fairly large tooth decay to find that. You wouldn't be able to see small ones. You wouldn't be able to see cracks. But dentists would use that. It was unreliable compared to X-ray, because when X-ray came about, after 1895, there was just no reason for doing oral galvanism. And it's not a good test today for dental infection and cavities. However, that's not what I'm doing it for. Let's go back to our patients with neurological syndromes. If you've got a neurological syndrome that might be suspected to be a brainstem problem, what is your brainstem? Well, it's your mesencephalon, your pons, and your medulla oblongata, which are the upper, middle, and lower parts of your brainstem at the bottom of your brain, above your spinal cord, right in front of your cerebellum, at the bottom of your head. So if you have symptoms that involve motor or sensory portions of your pons, it's really important to understand that the trigeminal nerve that innervates the alveolar nerves of your teeth carries sensory information and voltage-gated channels back to your pons, to the trigeminal nucleus, the fifth nucleus, which is in your pons. So if a person has a electrical discharge that's of a direct current nature, they could activate voltage-gated channels that would fire the sensory nerves of their trigeminal nerve that would fire along these alveolar nerves in the maxilla and mandible back along that trigeminal nerve to the trigeminal sensory nucleus in the pons. And they could begin to increase electrical activity in that pons that's not supposed to be there. And if it's unilateral, if it's one side more than the other, or it's asymmetrical, it could cause devastating changes in the balance of the electrical activity of the right and left sensory nucleus of the pons. This can lead to motor problems, it can lead to sensory problems, it can lead to perceptual problems, it can lead to vascular problems, because all of those areas have a watershed of blood flow that is controlled by the sensory input and by your activation of the sympathetic sensory nerves that sense that something has been signaled. Whenever you touch your face, whenever you have any kind of sensory activity, whether it be electrical from teeth or just touch, that increases just a little bit of your autonomic nervous system that says, hey, maybe some movement's coming. Maybe I need some more blood flow to cover that area of skin and that area of brain that perceives that skin. So by having a possible excess oral galvanism, direct current, you might have excess sensory input, excess sympathetic input, and excess changes of blood flow in your brainstem and excess activations or inhibitions of your brainstem. There are implications of this because there are tracts that flow through the pons that go up and down, and there are nuclei in the pons that determine what happens above and below. There are a lot of them, and we're not going to discuss them today, but the idea of oral galvanism is one that has to do with functional neurology and functional assessment, and it's not very useful for diagnosing pathology, because essentially there's no pathology. What we have is a dysfunction of electrical firing patterns that go away as soon as the galvanism is stopped. And once we stop the galvanism, we see that the patient feels better. And after the dental revision is done and they cleaned up whatever was generating the electrical current, whether it be metal in the mouth or decay or whatever metal source was generating electrical current, and whether it was positive or negative, after that was revised and cleaned up and gone, the dentist would redo oral galvanism and see that it had gone back to nearly zero or some level of noise, so that the signal to noise ratio was really favorable. When that happens, we really found a root cause for these patients. And sometimes even the dentist would paint over objects in the mouth with some kind of adhesive, acting as a temporary insulator that wouldn't conduct electricity. He would put some kind of a adhesive over top and paint it so that it couldn't conduct electricity. Now that didn't last very long, but it would be for a short period of time, and he might find that when it stopped the electrical activity, the patient felt better for a short period of time. And while that's not a permanent fix, it was a great diagnostic tool because it helped us say, hey, if we block this electrical current, do your symptoms reduce? And lo and behold, they would. In some cases, they wouldn't. And if we wanted to do a real proper study of the brainstem, we'd have to do a brainstem auditory evoked potential or a sensory evoked potential through the face to truly measure this. And we couldn't do that on these patients. But that would be something that could be useful and might help us understand if this were actually happening. So oral galvanism is not a diagnosis of pathology. It's used in functional medicine, and it's used as a guide, and it is never used by itself because some people have high oral galvanism and it's not causing them a problem at all. But when it can be correlated, it can be highly useful. Thank you.